Yeah, hi everybody. Um, Thanks for coming tonight. I know it's a little a little late, but my presentation is over Kirby's roll of 20, which I know a lot of you are probably like, what does that even mean? Well, let's see. So basically, hopefully you can see this okay, but it's not the little guy from Mario Kirby that we think of. It's actually named after a double board certified criticalist and internist named Dr. Rebecca Kirby. It's a checklist that makes sure that we aren't missing anything with our patient, that we're looking at them as a whole, not just one single problem. And it's, great for patients that are not getting better and we can't figure out why. Just going back to making sure it's not one problem that we're looking at. Just for example, diabetics, a lot of times, they don't just have diabetes, they'll have some type of ongoing infection, some type of pancreatitis or kidney disease or something else. Just making sure that we are looking at everything going on with that patient. And so I know this is a little daunting, but this is the 1 through 20, just the list version of Kirby's rule of 20. And don't worry about like memorizing this or writing it down. I myself couldn't go through these lists like 1 through 20 and name all these off right away. So I have the next slide. It's broken down into, for me at least, it's a lot easier to comprehend and go through in my head, breaking them down into a vitals assessment, laboratory assessment, and nursing assessment. So, it's going through, your patient, the vitals that we're always asked to get, the easy stuff, and then some of the lab and nursing things, just to keep in the back of our minds, which I'll go through in just a second. So first one is our vitals assessment. We're going through our mentation, our heart rate, rhythm, contractility, blood pressure, temperature, and then oxygenation and ventilation. And just a little side note, we need to know our canine and feline adult normals, but also, remembering the life cycle that the patient is in. So a temperature of 1025 for a normal adult canine, not too worrying. Maybe they're starting to get a fever, maybe they're a little bit hot, who knows. But a temperature of 102.5 in a 3-day-old neonatal canine, that's pretty much a heat stroke. So we want to make sure that we, I'm not going into that in the scope of this lecture, but just knowing our baseline normals for the life cycles of our patients. And then, so first up for our vitals assessment in Kirby's rule of 20 is mentation. We're always going to need to look at, what does this animal look like? How's it acting? Just straight off the bat, because we could have a totally normal TPR, totally normal blood pressure, and we could have patients that are looking back at us like this. The top left version is, normal for this cat because she was just underwent an anesthetic procedure. But then we look at the bottom left at this dog, totally not normal. His vital signs were completely normal, but then he could not even lift his head. So something was very neurologically not normal with this dog, despite his other vital signs. So you need to be cognizant of, how they're presenting to us, and documenting that as well. And just one of the tools that we can use to, especially with our neuro kids, if they are comatose or their neurological status starts to decline, we can use something called the modified Glasgow coma scale. It's basically a scale that can be used for not just a single neurological assessment. It needs to be done in serial, several different readings over a few hours, and it's super easy. You can Google it, but it just helps us to see if our patient's decompensating. So giving a score for each patient on, obviously the bottom left creature would get a much, the score would be a lot different from just our anesthetized waking up from surgery kitty up in the top left. And then next up is our heart rate, rhythm, and contractility. So measuring that with our good old stethoscope and ECG. I think we take for granted just what exactly our stethoscope is doing each time we stick it in our ears, but we're listening to the mechanical activity of the heart, listening for abnormal heart sounds, what is actually going on, in their chest that we can auscult. And then, our ECG also, I think sometimes we take that for granted, the electrical activity of the heart. And, if there are abnormalities of each, we need to be interpreting them together, not just, I think I maybe heard a murmur. I think this patient's under anesthesia and, it's throwing VPCs. We need to listen, we need to auscult and interpret that ECG together to get a complete picture of what's going on with the heart and how it's functioning. And that cat's adorable. Next up is temperature. And I included the poster child for our heat strokes, especially down in Texas, the English Bulldog. And then from the opposite side of the scale, my no body fat always thinks she's super cold. American Pit Bull Terrier Petunia has to have her sweater on because she's always freezing. So another thing I think we take for granted is just, temperature measurement and, making sure that we are interpreting that appropriately. So normal body temperature, at its base cause is, it helps maintain perfusion to the patient's organs and the periphery. If one of my big soapboxes that I like to stand on is I am not going to try and get a patient's blood pressure if their temperature is too low to read because they're not perfusing. So it's not going to be adequate. So with our hyper and hypothermic patients, first, if they're hyperthermic, we need to distinguish if that is a true fever, pyrexia, or if it is true hyperthermia, aka a heat stroke. So patients with a true fever, like with infection, they're not going to benefit from active cooling. They, fans, ice packs, anything like that, it's just going to further compromise their immune system and make them feel a whole lot worse. Imagine, when you have a fever, hot and cold chills, somebody puts a fan on you when all you want to do is cuddle up under the blankets and, ride that fever out, or someone, sticking you in an ice bath, and it is just not enjoyable and it's not going to help you heal because that fever is protective. So if we do, decide that it is true hyperthermia, like a heat stroke, or if, they've seized their brains out and they need our help to cool them off, we're addressing that through active cooling measures, fans, IV fluids. And then for our hypothermic patients, a little bit easier, no matter the reason why they are cold, we are still gonna warm them up the same way. If it's because of an external problem, the environment, or an internal problem, they're septic, we're still gonna warm them up. A bear hugger, blankets, warm IV fluids, one of my favorites, sweaters. So we're temperature's always one of our big hitters in our initial vitals assessment. And then for blood pressure, at its base, core, simplistic definition, assessment of cardiac output and perfusion. So like I said before, going along with that temperature, you know, if they have a temperature too low to read, I'm not going to get a blood pressure because they're not perfusing. So our two different types of blood pressure measurements, we've got our invasive, which involves direct arterial monitoring. You either have to have a, well, you do, you have to have an arterial catheter and the equipment to be able to do invasive blood pressure measurements, which is the gold standard because it's, you know, in real time and it's the most accurate, but it is the most invasive. So a lot of times we'll, you know, reserve that for our patients under anesthesia or mechanically ventilated patients, or a patient that's really not moving around but on vasopressors. And then for our non-invasive, which is most common, easiest to get, we've got our Doppler and our oscillometric, which is basically that little digital, everybody has their names for the different types of, you know, Cardell, Surgivet, their own little nicknames, but basically anything that is pumping the cuff for you and giving you a digital measurement is a oscillometric. And a lot of times with our kitties, it's a lot less invasive and less stressful for them to use this, but also remember we're taking it with a grain of salt. Doppler is more accurate, but it can be more stressful for them. So biggest thing for me is consistency. We always need to document the blood pressure cuff size, where we're getting the measurement from, the limb used, the type of technique we're using, whether it be, you know, Doppler, oscillometric, or it would be obvious if you're using a arterial catheter for measurement, but you know, super easy, just number 2 cuff, right front, Doppler. And then we always need to be documenting a paired heart rate with the patient's blood pressure at the time of reading, just because, you know, if they have a low heart rate and a super high blood pressure, or, you know, the opposite, that could give us a better idea of what's going on with that patient and kind of clue us as nurses and, you know, our doctors into something that we need to look into further, that could, you know, give us a reason why this patient is acting the way it is, or giving us, you know, a reason why they are mentally inappropriate. So always heart rate and blood pressure, we need to document those together. Also, that cat's adorable. And then our poster children, again, for problems is our English Bulldog. We're going over oxygenation and ventilation. So at its base, again, information about our patient's respiratory status. So oxygenation is how well the oxygen is being diffused from the alveoli in the lungs, then bound hemoglobin in the blood, and then transported to the body tissues. So, you know, indirectly, we're going to measure that with our pulse ox or SpO2. Another thing with these monitoring equipment, we need to be documenting where we're getting it from. You know, pulse ox obtained on the patient's lip, room air. And then we also need to be taking that measurement with, you know, with some critical thinking skills, because if, you know, the patient's looking great, walking around, seems to be breathing great, and you get a reading of 50, not possible, or the heart rate is not matching, you know, we need to, you know, take that into consideration and not take that for face value and look at the patient as a whole versus just that one measurement. And then our gold standard for oxygenation measurement is going to be an arterial blood gas sample, which, you know, is more invasive, but especially for our patients that are, you know, receiving oxygen supplementation, whether that be high flow, mechanical ventilation, under anesthesia, that is going to be our gold standard, is an arterial blood sample. And then for ventilation, that's driven by our patient's CO2. Excuse me. Driven by our patient's CO2. Sorry, that was a good verb. Our end-tidal is measured with in our intubated patients to give us how adequately they're ventilated, also utilizing that during CPR to see how effectively we're performing that for our patients. And then again, gold standard to see how our patients ventilating is going to be an arterial blood gas sample. So, a lot of these seem invasive, but just swinging back around to, on the right side of the screen, what we easily measure and, can keep a very close eye on and are the eyes and ears for our doctors and our patients is just monitoring their respiratory rate, the character of their respirations, the effort, and, actually listening and ausculting their chest and making sure that we don't hear, any crackles and wheezing, and documenting that appropriately, because that can also clue us into other things that are also on this list a little bit later on. And for our next assessment section is lab, which is sectioned off into fluid balance, albumin, oncotic pull, electrolyte and acid base, red blood cell and hemoglobin, coagulation cascade, renal function, and glucose. So for fluid balance, it's, our patients are 60 to 65% water weight. So that is huge. So just an easy way to help us keep track of this. It is a small thing, but again, this is where we as nurses are, the eyes and ears and the advocates for our patients and our doctors, is just monitoring their mucous membrane color, their CRT, respiratory rate, respiratory effort, and their weight. A lot of times we'll, especially if it's a patient with a heart murmur or, a patient at risk of fluid overload, will do more than Q12 weights, Q6 to Q8 hours to see how big of a change that they are holding on to that fluid. And we do need to take time throughout our shift, just to double check the patient's IV fluid rate, make sure that it's, the correct fluid, make sure any of the additives are, correctly calculated and actually, being received by the patient, and that it matches their actual fluid therapy orders. And just bottom, signs to watch for fluid overload, clear nasal discharge, coughing, increased respiratory rate and effort, and then increases in weight. So, top right is kind of the poster child to watch for fluid overload. That was my friend Cupcake. She was a DKA, CHF, IBD, CKD, ball of just internal medicine fluid overload warning, flashing, screaming. So she is, all of her comorbidities gave us kind of a head start in watching to make sure she did not get fluid overloaded, which is, pretty hard and something that needs fluids, but we don't want a fluid overload. And next up is albumin and oncotic pull. So, I'm sure we all have heard of albumin before, but what exactly does it do? It's, a protein that's within the intravascular space that helps to maintain vascular integrity, which is a lot of fancy words for it keeps the fluids in the veins that are supposed to be there. And then just to tie in with albumin is our colloid osmotic pressure, which is the pressure generated by the proteins, albumin, that can't be easily moved between the vasculature. So both of those together, without them, without, one and or the other, the fluids are going to leak out of the intravascular space, cause third spacing of so the fluids accumulating, and then we see, like in the top left picture, edema forming, whether it be peripheral edema or facial edema in that Frenchie. A lot of our parvo babies will have to worry about their albumin and oncotic full, just because they're losing so many fluids and can't keep any of their fluids inside their vessels. So bottom is a Frenchie that was a attack by that, his albumin got so low that he needed definitely some colloid support there. Let's see. And then electrolyte and acid base. So essential for cell function and fluid balance. These all, you can kind of see how these are all tying together a little bit. So sodium, potassium chloride are the main three that we are keeping a close eye on. Just our simple little light clip that we run. Potassium being the most common one that we see suffer imbalances with our critical kids. And then we're seeing severe changes in electrolytes that can result in changes in their mentation, their ECG, and their acid-base status. So why did I include this cute little ECG in the top? I just want to show how we are needing to look at the both versions of the both ends of the spectrum in our hypo and hyper electrolyte imbalances. So hyperkalemia, tall tinted T waves, we'll see these a lot in our block kitties. Their potassium doesn't have anywhere to go, so it's just building up. In our Addisonian kids, a lot of times we'll hook them up to an ECG and they have a high potassium, tall tinted T waves. And then opposite end of the spectrum are hypokalemic friends. This adorable cat, pretty poster child for a CKD kitty that muscle wasted. It's got the plantigrade dropped hawk stance in the back, muscle weakness, and then the ventroflexion of the neck. So that alone can be, just a physical sign of hypokalemia. And then our acid-base status, which I can go into a whole nother presentation on, which I will not, but it basically can help us determine whether our patient is acidotic, whether it's alkalemic, and whether it's experiencing those issues with a respiratory or metabolic imbalance at hand. Super important with our CHF kids, our UO kitties, our DKAs, probably most commonly that we're familiar with when you hear acid base, we'll thinking of DKAs, but also our ethylene glycol toxicities. Red blood cells and hemoglobin, so responsible for delivery of oxygen throughout the body. We're monitoring those to better assess the patient's oxygenation, since, as we know, oxygen binds to hemoglobin. We're monitoring their CBC, their packed cell volume, and then easy ways that us as technicians can monitor this without being invasive is, are they tachycardic? Do they have an increased respiratory rate or effort? Are they pale? That's one of our biggest ones. Are they super lethargic, or do they have an altered mentation? And then I just included a nice little IMHA diff that is obviously not a healthy blood smear. And then coagulation cascade, which I can also do an entirely different singular presentation on. Super interesting, but just for the scope of this lecture, it's the cascades responsible for creating, maintaining, and destroying blood clots. If any area of the cascade is affected, we could see prolonged or short clotting times. If they're prolonged, A lot of times, like in our rat bait kids, we can see uncontrollable bleeding. And then if they have rapid or short clotting times, they could be hypercoagulable, so at risk of thromboembolism, PTE, aka throwing a clot. And how we as technicians are, applying this rule to me. We're monitoring the patients for clinical signs of bleeding. So we're looking for petechia if they have little pinpoint bruises, a lot of times on the gums, prepuce, vulva, a lot of times on their tummies it'll be hiding, or ecchymosis, those larger bruises, like in the bottom left-hand quarter that we'll see, or even bloody urine. And then we're making sure that before we go poking a patient's jugular vein, we're making sure that they have an adequate platelet count, monitoring their PT, PTT if indicated, and evaluating those different parameters together to make sure that we're that they're adequately clotting. And then again, not poking their jugular vein, because that could, if they are either hyper or hypocoagulable, cause issues either way that we don't want to have to deal with. Look at that cat. It's our classic crunchy CKD kitty, muscle wasted, and muscle weakness, but just ties into our renal function. So our kidneys are pretty important. They are responsible for maintaining fluid balance. They play a hand in hormone production and urine production. They filter out, the waste of the body, the BUN, the creatinine, and we're monitoring that with our BUN, creatinine, potassium, phosphorus levels. And a lot of times we'll also get a blood pressure with, if we're worried about their kidneys, we'll look into hypertension as well, urine output, and serial body weights. Next up is glucose. I like this picture, but I'm fully aware that that reads like a lactometer versus a glucometer. So just don't look at the number, otherwise it's a good picture. So glucose is the body's primary energy source. It is most frequently monitored with the glucometer using a drop of whole blood, and we need to be comparing those. If we're getting a single high or a single low measurement, we need to compare those to other measurements that we're getting, not just a single measurement. And then this is another area where we can really shine as nurses, applying those critical thinking skills for the changes in blood glucose. So, you have a 1-month-old little white Maltese puppy that is, not conscious, comes in limp. What's the very first thing that we're going to check? Their BG. So situationally, we need to think of why they their glucose is doing what it's doing. Stress. A lot of times our kitty friends can have iatrogenic or just a stress hyperglycemia just from being out of their element. Our diabetics, toxins like our xylitol toxicities, sepsis, liver disease, and there's definitely too many to name, but there's just a few. And then this is always interesting to me, and always something that you need to keep in the back of your mind. But if a patient is super dehydrated, especially like our little super severe HGE chihuahuas, if they have an increased pack cell volume, any patient, but that's just one that I can think of that could be used in this example. But we can either get really high or really low BGs that are not correct just because they have so little plasma volume going through their body because of the dehydration. So a lot of times, we can get this high or low BG, and then, people will start freaking out, but then light bulb is probably not real because they're so dehydrated. So we'll rehydrate these kids and then get an accurate BG, and hopefully we won't have to deal with any type of supplementation. And then for our last section, one of my favorite sections, our nursing section, we've got nutrition, gastrointestinal motility and integrity, drug dosage and metabolism, pain control, immune status, antibiotic coverage, wound healing and bandages, and nursing care and TLC. Sorry, Hootie just bumped me. So first up, nutrition. I'm sure we've heard this before, but if the gut works, use it. Basically, the earlier nutrition is able to be started on these kids, the better the body can heal. So we need to introduce food as soon as we can when we're able to, or have a plan in their treatment plan when we are going to start that. Our right side is examples of our parvo puppies within G tubes. Bottom left is our adorable E-tube kitty, and then top left is kittens. I'm sure we've all had the kitten that's come in that is not eating and is limp, and we think, oh, something's terribly wrong, and sometimes there is, but sometimes it's just not getting stinky enough food. So you offer it some AD, some gruel, and hey, this is the result that you get. But so we're most commonly just starting out by offering warm food by hand, chicken, baby food, anything that smells good. I love offering dogs cat food because what dog doesn't love cat food? And then trying an appetite stimulant when appropriate, or if we do need to place a nasogastric tube or an E-tube, giving nutrition through those. And then cases where we can't give them nutrition through their GI tract, IV nutrition or parenteral nutrition is an option, but it's very uncommon and not used a whole lot anymore. And then for our GI motility and integrity, we are always concerned about that, especially with our canine patients. Their shock organ is their GI tract. So any little bit of stress, even just being hospitalized, can, cause their GI integrity to not be appropriate. So, they can get gastric ulcers, they can, have ileus, which is super uncomfortable, or just their altered GI tract permeability. And then we're assessing it through their abdominal palpation and then monitoring, their vomiting. Are they regurgitating? What type of defecation are they having? And if they are, having an appetite. And then, antiemetics, GI protectants, and prokinetics should be considered. If you have a patient that's continuing to regurg or continuing, to not eat, continuing, to be uncomfortable in their abdomen, this is another area where we can really advocate, hey, what about a dose of Serenio? What about XYZ, just to, make them more comfortable thinking about their GI integrity. And then one of my favorites is nasogastric tube placement for patients with ileus. It can help make them more comfortable by being able to remove all that gastric residual volume off their tummies. One of my absolute favorite scenarios is, placing that nasogastric tube in that patient, and whether it be a dog or a cat, especially parvo puppies, that are just super uncomfortable, have a ton of fluid on their stomachs, and then you suction all that fluid off for that first time, and you hear them and feel them take that deep breath where they can actually inflate their lungs and don't feel like they're going to regurge. That to me as a nurse is super satisfying, being able to help our patients that way. And then, you know, a lot of times when we have a stomach ache, we are not gonna want to get up and walk or exercise or do anything, but it is proven that increasing you know, your mobility, getting up and walking can help get the GI tract moving. So increasing amount of walks. A lot of times with our food bloat kids, we'll walk them every 2 hours just to keep that GI tract moving. Drug dosage and metabolism. So for me, if you're not familiar with the medication, before giving that medication, you need to educate yourself. You need to, you know, look it up in Plums, ask one of your coworkers, you know, why am I giving this medication? What are, you know, the possible side effects? What do I need to be watching for? And for me, never be afraid to have someone double check, you know, your math, your the amount you've pulled up, anything like that. I will have so much more respect for someone that asks me to double check their work than someone that, you know, is not afraid to make a mistake, because that should always be somewhere in the back of your mind. And that's what our 5 rights of drug administration are for, you know, making sure that we are giving the right patient the right medication, that is the right dose of the medication, that we're using the right route for that patient, and then, you know, are we using the medication at the correct time interval. So just going through those every time you're giving a medication through your head, in your head, it seems like a little bit of cumbersome, but one of those things that once you do it and get in a good flow of it, it makes you a better nurse. So again, I always you know, really encourage people to understand what we're giving medication wise and why we're giving it. One of my favorite assessment parts of the nursing assessment is pain control. Again, this is where I think we as nurses really, we're our patient's biggest advocate. We are the eyes and ears, we're with them all the time. They can't tell their doctor that they want pain meds. We can. And, you know, using pain scores, you know, different type of scales. This scale is super, it's just an example, but it's you know, just showing the type of scale. This is super simplistic, but you know, we use a lot more in-depth pain scoring systems. Hopefully you do it at your hospital as well, but it just helps take into not only their their demeanor, how they're acting physically, but also you know, their vital signs. So, you know, not just them vocalizing or being restless or agitated, but also, you know, they have a high heart rate. Are they panting? Are they not comfortable? You know, do they have a high blood pressure? So we need to be continually assessing, you know, their comfort and their pain score throughout their hospitalization. Almost all critical patients will benefit from some type of pain control or, you know, anti-anxiety medication while they're being hospitalized. So again, this is somewhere where I feel like we as nurses can especially advocate for our patients. For immune status and antibiotic coverage, you know, it's super important to keep in mind with our hospitalized patients. They're, the simplistic explanation for the immune system is it's just helps protect the body. And no matter why a patient's being hospitalized, just the stress of hospitalization, being out of their normal, most animals that present to us will have some type of decreased immune function. So whether it's just a toxin ingestion that is barking its head off, just the stress from that alone can cause our immune system, their immune function to be decreased. And then soapbox of mine is, wearing gloves with every single patient every time, but especially with our immune compromised patients, like our, the picture above is showing our a chemo friend of ours that, with full PPE, protecting ourselves and that patient. But I really encourage you to, as a profession, as a fellow nurse, to try and wear gloves with every single patient. My argument for that is, imagine going to a human hospital and, having a human nurse place an IV on you without gloves. They could be the best nurse in the world, but just the example of them doing that without gloves automatically takes them down a peg in my book, because of the care that they are not giving as a standard for their profession. I'll get off my soapbox for that. And then, immune status, where monitoring their white blood cell count and their temperature. A lot of times that can give us signs, if they're becoming septic, or if they do need antibiotics. We've gotten a lot better about this as a profession, but not just throwing antibiotics at animals. If they have a fever, we need to really go case by case and assess the pros and cons of what this antibiotic could potentially do or not do for this patient. And for wound healing and bandages, which is part of our nursing assessment, this is referring to traumatic wounds, surgical incisions, and insertion sites, drains placed in wounds, our Jackson Pratts, our Penrose, or surgical incisions. Basically, what we are telling the owners to check for when we send these patients home, we need to be watching for diligently while they're being hospitalized. So, signs of redness, swelling, discharge, signs of infection, examining our insertion sites, our IV catheters, where our feeding tubes are sutured in, our central lines, if they have any bandages corresponding to that. And changing those sooner or daily or sooner if they become soiled. And then another soapbox of mine is inspecting patients' catheter sites daily. A lot can hide under that tape. They were looking for redness, swelling, phlebitis. We're monitoring the limb above and below the insertion site for any signs of swelling or edema. This picture in the top right is just an example. This was a parvo puppy that was hospitalized, did not get his IV catheter tape taken all the way down to the catheter. Above the insertion site and below the insertion site, no swelling, no redness, looked great. No fever, patient wasn't favoring the limb or anything. But when we took down that tape, he had a pressure sore from his T-port that we had inadvertently caused. So, the tape looked great without untaping it, but then underneath, this is what we found. So not only is this kid, dealing with parvo, he's also trying to deal with this pressure sore that's obviously looks pretty ouchy. So that's my example for why we need to be looking at these insertion sites. And then for this top left picture is a patient that had from a heating pad, a full thickness burn all the way around his rectum, his tail, and top of his back, just being mindful of where these wounds are located, and how the patient is living with them. This patient was very uncomfortable because of the burn, but we also had to be super mindful of him getting feces directly into that burn. So again, being mindful of where the wound actually is as well. Nursing care, one of my favorites. This is something that comes naturally to a lot of us. And it just makes you feel good as a nurse, being able to make your patient feel more comfortable with super easy things that honestly don't take a lot of effort. So, ensuring that they have a clean bed, a dry bed, that it's comfortable, that they can actually rest, especially in our recumbent patients. That this picture is a 10-year-old Great Dane that was super emaciated and already had some pressure sores, but she has a nice couple-inch thick pad that's waterproof on the bottom of her kennel, couple comforters, and then a pillow elevating her head, and she looks pretty darn comfy. I would sleep in that bed. But again, our recumbent patients, making sure that we're changing their recumbency, passive range of motion for their muscles, keeping them clean, and making sure they aren't getting bed sores, making sure that this is a big soapbox of mine as well, our treatments are done as much as we can when the patient's status allows us to. We're doing treatments in bulk. We're not doing a patient's TPR, then the next hour walking them, then the next hour feeding them. We need to try to do all of that at once so they can actually rest in between times. And then during the day, whether it's a patient that we can carry outside or that we can gurney outside, just getting them outside, getting them away from the four walls of the cage that they're constantly in, that they don't have a choice of getting up and moving around, putting them in the grass, letting them feel the wind, feel the grass, smell all the different smells outside that aren't a hospital. And then, just sitting out there for a couple minutes. And then at night, our night shift can, when they're able to, try dimming the lights, turning the lights off, giving them a good, at daytime and nighttime, keeping that cycle as close to their normal as we can. And then another favorite of mine is just good old TLC. This can help with anxiety and stress, and which leads to better healing. Spending time with your patients, truly caring for them. That's why most of us got into this field. So petting them, brushing them, talking to them, treating them like pets, and just showing them a little bit of extra love can go a long way. This is my example of a super easy how I apply to Kirby's Rule of 20 as a technician. This is a post-op TPLO pity that all the boxes were checked. She was not in pain. She had already went to the bathroom. Her vital signs were normal. She had eaten, and bed was nice and clean. Ticked off all the boxes for me. But being a pity, she did not have a blanket covering her. So I took it upon myself to, get a nice comforter, cover her up. And lo and behold, she actually laid down and fell asleep. And then I was able to, like a little kid that's you let fall asleep on the couch, I was able to walk away, and she just kept sleeping until her next treatment time. So just little things like this can make a big difference in how your patient deals with their hospital stay. And that's it for my my big Kirby's Rule of 20 assessments. I just wanted to give a little, it's past the scope of this this lecture, but I wanted to just give a example of how we can apply this in real time, besides that little pitty easy one. My criticalist is really good about for her consults, she uses Kirby's Rule of 20 just to go over, and then she'll for each of these patients, and then make a recommendation of you know, what to do for the problems in this list. I had to kind of condense everything, so couldn't fit everything on one slide, but it makes more sense at the end. So this is Miss Maggie. She was a 2-month-old female intact 1 kg little Maltese puppy. She was parvo positive. They tried outpatient treatment. She continued to decline. She was hospitalized, excuse me, and then on day 2 of hospitalization, she still wasn't improving. She was hypotensive despite a bunch of fluid boluses, hypoglycemic, hypokalemic, hypoalbuminemic, not eating, ileus, diarrhea, parvo. So this is how we applied our Kirby's Rule of 20 for this little girl. You know, for our vitals assessment, she was very dull, but most likely due to her hypovolemia, just from losing so much fluid through her GI tract. Not concerned about her heart rate and rhythm, blood pressure, very concerned. She was continually hypotensive due to her poor colloid osmotic pressure. She was hypoalbuminemic, so you know, both of those going against each other. Blood pressure was surprisingly normal, and her oxygenation was good. So fluid balance, again, she was hypovolemic, also hypoalbuminemic. Not surprised, but her potassium was low, so keeping a close eye on that. You know, really focusing back in on her decreased albumin and her poor oncotic pull. Everything else on this page except for her glucose. You know, being a 1 kg little Maltese puppy, she was hypoglycemic, so we were supplementing her. And then for our nursing assessment, for our drug dose and metabolism, we were she was on a good parvo puppy protocol. She was, you know, already on the support that she needed to be on, medication wise and fluid wise. You know, she at this point did not have an NG tube, so we placed that. You know, starting her nutrition, super important. Her GI tract motility and integrity, horrible, parvo. You know, we're making sure not to over aspirate this tube because she's so small, because we can cause other problems. Continuing that metoclopramide for that prokinetic, and then barium for also to, you know, help coat her GI tract and hopefully get some of her ileus under control. Her immune status and antibiotics, you know, horrible. She has parvo, so due to her size, we're just doing daily diffs and then added Baytril on. Pain control on gabapentin, but since she's not really absorbing anything through her GI tract, if she needs it, we'll give her some low dose buprenex. And then for our TLC and nursing care, I'm going to make sure she's, you know, with our parvo puppies, a lot of times it's a challenge to keep them clean and dry, making sure that she's not getting fecal urine scalded, and then of course some infectious disease approved cuddles. And then again, this is why I couldn't fit everything in, but just this is how we can apply Kirby's Rule of 20. You know, she goes into saying why we're not doing you know, big blood draws on this tiny patient. We don't want to exsanguinate her. You know, recommendations going forward, you know, monitoring her weight, some IV fluid therapy recommendations, some recommendations to, you know, get her albumin back up and help support her colloid osmotic pressure. And then, you know, like I talked about before, even though she is in isolation, you know, putting potty pads down on the floor, you know, keeping her hooked up to her fluids, but putting her on the floor, letting her walk around, let her be a puppy, while still giving her the TLC that she needs because she is a baby. So I just thought this is a great example of this. Goes more in depth into what the scope of this presentation is, but just shows you how easily you can apply it. And then, just summarizing, this was the first Lyoki kitten I ever got to meet, so I was pretty excited. Monitoring these, it seems like 20 is a lot, but when we break them down into, the vital signs, the laboratory and nursing assessments, it just allows better understanding for how we can ensure that we're meeting the major needs of our patients each and every time. It helps, at least for me as a nurse, it's helped me, improve my critical thinking skills and, especially medication wise, learn, the why behind what I'm doing, and just helps me provide the best care, and hopefully helps you guys provide the best care you can or feel like you can as nurses, and are able to do so in the future.